Welcome everyone. This is a short presentation on the topic of imaging of osteonecrosis. Imaging of osteonecrosis made by me. So let's start. Osteonecrosis or avascular necrosis, as the term implies simply, avascular means there is no blood supply, and necrosis, as we all know, means death of a tissue. So osteonecrosis or avascular necrosis of bone simply means it's a death of a bone secondary to the interruption of blood supply. Okay, next. Now there is in the body there are various locations where there is avascular necrosis commonly seen. The most common location is hip. The second most common location is shoulder. Another apart from that, there is talus fracture talus. Though there is talus fracture and many other areas like lunate, navicular bone, where the avascular necrosis is seen. I will discuss it one by one. Now, before going to imaging feature, let us just quickly review the pathophysiology behind the avascular necrosis. If there is interruption of the arterial supply to the bone, there will be necrosis. And if we just see it, the necrotic portion will be present in the center. Now, as soon as there is necrosis, there is a feed forward cycle, or simply say our body's compensatory mechanism gets started. So in the core region there will be a necrotic tissue. Around the core necrotic portion, the region will be hypoperfused. But due to compensatory mechanism under the ischemic risk, there will be a compensatory hyperemia after the hypoperfused region, and between the hypoperfused region and the normal viable tissue there will be deposition of granulation tissue, and this is the basis behind the double rim sign or double line sign, in which is seen in T2-weighted image in MRI. We will discuss it later. So just for the time being, there is a necrotic center. Surrounding it there is a hypoperfused region. Surrounding there is a granulation tissue which is still viable, and it is the junction point between the viable tissue and the non-viable tissue, and after that there is a normal viable tissue. Next, the causes. Although there is a list of causes available in every books, I have just taken the salient causes which is most commonly available. So the most common cause of avascular necrosis is trauma. This is an MCQ question asked in NEET PG. What are the most common causes of avascular necrosis? Is definitely trauma, and I have already mentioned that the most common site is hip, and it is basically it is seen in fracture neck of femur, trauma, and it result into the avascular necrosis of hip. The reason is the interruption of the blood supply. So just a quick review. I will not go into detail of blood supply of femoral head, just a short review. The main blood supply of the femoral head is the medial circumflex femoral artery. Actually there is a formation of a capsular ring in the femoral head, we all know. So the main blood supply is from the medial circumflex femoral artery, and actually these blood vessel is branches of these blood vessels, if you see, is oriented along the long axis of the femoral neck. So if there is any fracture in the femoral neck which is causing the interruption of the blood supply, so resulting in the avascular necrosis of hip or femoral head, whatever the thing is. So the main blood supply is from the medial circumflex femoral artery, and in some patient population the blood supply, that is that artery to ligamentum teres, it's a branch of obturator artery or foveal artery, also called as foveal artery, is also a main blood supply to the femoral head. So in other causes, steroid, chronic long term steroid use is also a cause. Apart from that, sickle cell disease, Cassion disease is also a cause. The pathogenesis behind this all this thing is that interruption of the blood supply. If you all know that sickle cell in anemia, the red blood cell get shape is altered, and there is under stress there is hypoperfusion. The capillaries get clogged with the sickle cell RBC, and there is interruption of blood supply to the femoral head, so resulting in avascular necrosis of hip. So two more important point I want to know, that there is an idiopathic, the 5% in 5% cases of avascular necrosis there is no cause actually, so it is idiopathic. And especially in children there is an idiopathic cause in femoral head necrosis, that is known as Lake-Carp-Perthes disease. One point to note, that if the avascular necrosis the cause is trauma, it is obviously will be unilateral, but if it is due to systemic causes, then definitely there will be a bilateral avascular necrosis of hip. Another important point, or medico legally important point, is this avascular necrosis of hip. Usually the patient, as I discussed here, the patient presented with pain in hip, which is increase in walking and decrease in taking rest. Now what I mean, the pain gets aggravated on weight bearing. The pain gets aggravated. And now actually the important of radiology is here, the clinical presentation, the clinical presentation of avascular necrosis of hip is sometimes non-specific in nature. If clinician should be aware of the background of the patient. For example, I have written here that patient is a known case of renal transplant. Why? Renal transplant, we all know that after renal transplant usually the patient is put on a chronic steroid therapy, so which is a risk factor of avascular necrosis of hip. So avascular necrosis of hip. So imaging, actually it's a medical legal point of view, imaging plays an important role in the diagnosis of avascular necrosis rather than clinician. So this is the typical case of presentation, the female 30 years old which is presented to the chief with the chief complaint on pain on hip, and I am mentioning that pain is bilateral. I've already mentioned if it's due to the systemic causes, there is every possibility that the avascular necrosis will be seen in the both knees. There may be a slight variation in the progression, but usually it is seen in the both side. Next. Now first imaging modality, this is the question. First imaging modality is always X-ray. Now there is two questions. What is first? A patient presented with the avascular necrosis of hip to the OPD, what is the first investigation you will do? Is always X-ray. The first examination will be always X-ray, but the best is definitely MRI. Just 1 minute. Just 1 minute. 1 minute. Yeah, first imaging modality is always X-ray. Now what are the features we will look for in the X-ray? Firstly, if there is a femoral neck fracture, this is obvious, it will be an obvious. Second, collapse of articular cortex. The finding is collapse of the articular cortex, epiphyseal fragmentation and cystic radiolucency. Epiphyseal fragmentation and cystic radiolucency. Then see the images. This is an image. Can you see? This is the thing. Please see that there is a step defect. There is a step defect in the articular cortex. there is a stave defect in the articular cortex. Along with that, there is an sclerosis. There is a defect. Along with that, there is an sclerosis. Let's see. This is a stave defect, as I discussed, and there is homogeneous increase in the radio density, a increase in the density of the femoral head, which is sclerosis. This is a X-ray find feature seen in avascular necrosis. Its a diagram is the sharp angular deformity along with sclerosis. Next, I've told that epiphyseal fragmentation along with cystic radiolucency. Please note here, there is in this area is sclerotic zone, this area is radiolucent or cystic, radiolucency or cystic. So epiphyseal fragmentation, and this is cystic lucency. Third is subchondral fracture or cyst formation, which is also known as crescent sign, and I have already discussed this sclerosis of bone in the femoral head region. This is actually known as snow cap sign or head within head sign. It is also known as head within head, although the term more commonly used in Perthes disease, but this is a generic term. It is a snow cap sign or head within head appearance. It is called the increased density of the femoral head, and the location of this finding is usually in the anterosuperior weight bearing portion of the femoral head. Anterosuperior weight bearing portion of the femoral head. Okay. Next. Please see this image. I've told that subchondral fracture. Please, it's a very subtle finding. Let's zoom it. Can you see that there is a thin rim of radiolucency just beneath the articular cartilage. See here in the diagram, the thin curvilinear, I have seen thin curvilinear lucency beneath the weight bearing articular cortex. This is known as subchondral fracture. And according to the orthopedics literature, it is mentioned that presence of a subchondral fracture is a poor prognostic marker of avascular necrosis of hip. Okay. Next, this is another picture of same subchondral fracture, a thin radiolucent line just beneath the femoral head. Okay. Next. Okay, this is, I have already discussed this. There is increase in opacity or radiodensity in the femoral head region in a triangular fashion, which is called as snow cap sign or head within head appearance. Actually, the name of the sign is important for PG entrance examination. Snow cap sign is commonly seen in avascular necrosis of hip, or in general in any portion, in any avascular necrosis of any bone. We'll see it later. It's an image showing the progression of the avascular necrosis. Please see that at the initial point there is definitely increase in the radiodensity. Along with there is a stave defect. I've already discussed. There is a defect in the articular cartilage. After 1 year, please note that the contour of the femoral head, which was quite normal in the initial stage, is gradually getting deranged, and in the advanced stage, the femoral head contour is totally deranged with, please note, with there is lateral displacement of the femur, and also note please that the joint space between the acetabular roof and the femoral head is well maintained here, which is gradually decreased in this image. The joint space is decreased. Actually, when the avascular necrosis in the hip in the long run stage, it is not intervened, gradually the secondary degenerative changes comes into the picture. So this is it. Also the same image, this is the patchy sclerotic area of the femoral head, also known as bite sign, as a bite sign, and these also say collapse of the articular cartilage along with the decrease in the joint space. Okay. So these were the X-ray findings. Next come to the picture is MRI. Now MRI is the best and most sensitive part, and best and most sensitive imaging is the MRI. So first imaging, basic imaging will be on X-ray. Second or best, whatever say, is MRI. Now what is the advantage of MRI actually? Actually the advantage of the MRI is that it demonstrates the changes well before the plain film changes are visible. Actually there is a classification I have not mentioned here. This is more of orthopedic classification, but commonly asked in questions ki FICUT and FICUT and ARDLET classification. If you just Google this classification, you will see that it has 4 stages. In the first stages, the X-ray is absolutely normal, but there is changes in MRI and in scintigraphy. So there is the importance. If a clinician suspect that the patient has some risk factor of avian, but still the X-ray is normal, he or she must order an MRI. So this is very sensitive as well as specific to show us the changes of avascular necrosis of hip. Okay. Now there is a controversy. I don't know. In the classical teaching says that the bone marrow edema in the femoral head is the earliest clinical feature seen in the MRI. Also asked in this question as an MCQ in NEET PG. So earliest finding is bone marrow edema in the femoral head, but the recent some literature says that no, it is not like that. Earliest feature is not bone marrow edema. Bone marrow edema only appears after the pain. Patient presented with the pain, and a patient present with it. And one thing is there, the avascular necrosis of hip can last asymptomatic up to 5 years without any chief complaint. Up to 5 years it can remain asymptomatic without any clinical feature. So this is the thing. If there is risk factor, if you can do an MRI, we can see the changes. Anyway, earliest finding as it written in classical literature, bone marrow edema in the femoral head, it is the earliest finding in the avascular necrosis of hip. Second point, we'll discuss is more. It is in treatment portion. Key decompression. You see that this is more or less orthopedic topic. This is a decompression surgery is the treatment of choice for this avascular necrosis of hip. We have to release the pressure so that blood flow starts again. Decompression surgery is the treatment of choice. There are many treatments actually. This is not my purview. It is more orthopedics domain. But the basic point is decompression surgery is the main modality of treatment here. The principle. One point just think, if even after decompression surgery, post-operatively, bone marrow edema is persistent, then this is a poor prognostic. This is a poor prognostic marker. There is a poor prognostic marker for avascular necrosis of hip. Okay. Next point. This is the most sensitive. This is the very important and very specific. Most sensitive and specific. Whatever say pathognomic. This is the sign. Well, please, it is written circumscribed, well circumscribed geographic or serpentine pattern. In the anterosuperior portion of the femoral head. I have already told that anterosuperior portion is the most weight bearing portion of the femoral head. That's why most of the changes, whatever, be it X-ray, be it MRI, you will find in the anterosuperior portion. Okay. Most peripheral site, mostly affected area, whatever you say. This is the most important sign. Okay. Serpentine ring-like appearance of altered signal intensity, mostly seen in the anterior superior part. It is the sign. Okay, next sign is the double line sign. Actually, double line sign. Yeah, double line sign is not seen in every cases. It is up to 80% of cases show double line sign. It is in the T2 weighted image. Okay, it is in the T2 weighted image. T2 weighted image. Yeah. So what is double line sign? Double line sign is same. There will be two zone of intensity. The outer rim, actually the outer rim will be the hypointense, low intensity zone, and beneath that there will be a high intensity zone. So it's like a band, double band sign, double line sign, whatever the sign, whatever sign. And that means outer low intensity rim, inner side is the high intensity rim in 80% of cases, and it represents as a zone, it is zone of hyperemia and a granulation tissue. As I discussed earlier in the pathogenesis, that the viable tissue and the granulation tissue, the zone, this is actually the basic or pathogenesis behind the double line sign. Okay, two intensity, hypo bahar mein hypo intense, inside it is hyper intense, and it is seen not in all cases, it is seen up to 80% of cases. Yeah, this is, please see this, please see this is the serpentine pattern. This is the serpentine pattern of altered signal intensity, which I have discussed. It is seen in this is coronal, this is sagittal, in the both hip. Here it is seen in the both hip, or altered signal intensity of in serpiginous pattern. Yeah, this is the double line sign. Please see the outer side, there is T hypointense rim, in the inner side there is white. Yeah, yeah, this is, there is hypointense rim on the outside and hyperintense rim inside. This is double rim sign. Okay, okay. This double rim sign is actually was described by Mitchell, scientist Mitchell, and according to his name, it is also called the Mitchell sign. Okay, and there is a classification given by Mitchell classification. He has divided into the 4 classes, and this question actually I have seen in some FRCR examination question, true false pattern, 5 MCQ. If first it is fat signal, after that class B it will be blood signal intensity, after that it is fluid signal intensity, and then it is fibrous intensity. This class A means fat intensity, class B is blood intensity, class C is fluid intensity, class D is fibrous tissue intensity. And it is very obvious that class D is the most worst scenario, and class A is the earliest scenario. Okay, so blood signal intensity means T2 hyper intense, fluid signal intensity means T2 hyper intense. Blood, it is actually blood intensity is, it will equal subacute stage, actually subacute, late subacute stage. What in brain hemorrhage, the finding which we see that late subacute stage in brain hemorrhage, same type of signal intensity, that is T1 high and T2 high, both hypertension, T1 and T2. This is actually fat intensity followed by blood intensity followed by fluid followed by fibrous tissue. It is the central portion, please, in the central region, the changes of signal intensity with progression to time. This question, this fat signal followed by blood followed by fluid followed by fibrous tissue, this sometimes asked in MCQ questions. Okay, there are some apart from these two prominent MRI feature, there are some additional features. These are definitely non-specific. This is definitely non-specific, but when these features are also present, it supports the diagnosis. This is premature conversion of the hematopoietic bone marrow. Hematopoietic bone marrow से fatty tissue हो जाएगा. Premature conversion of the hematopoietic marrow into the fatty marrow in the intertrochanteric region. This is one feature. Second feature is the joint diffusion. Just see, this is an image. This is just compare. This is a fat suppressed image, ST image. So just see there is fatty infiltration, which on fat surface we can't see here, so definitely it is fat. Similarly here is also fat, so this is fatty infiltration, premature conversion of the fatty infiltration of the bone marrow. This is one feature. Second feature is fat surface. Even we can see the hyperintensity here, that means it's a bone marrow edema. So this bone marrow edema is I have told already that earliest feature of an avascular necrosis is bone marrow edema. Bone marrow edema, here you get the premature conversion of the fatty marrow, premature conversion of the bone marrow into the fatty infiltration. Next, second is I told you increased amount of synovial fluids, joint diffusion. Joint diffusion is also sometimes present in avascular necrosis of hip. See here, this is the joint diffusion. Okay. Now, whether should I use contrast or not use contrast? Some literature says yes, you can use contrast. I will put gadolinium contrast. If after putting contrast there is enhancement, that means the area is viable, and if it is not enhancing, then the area is necrotic zone, and this non-viable zone actually correspond to the scintigraphy cold spot. If you do scintigraphy bone scan, these areas correspond to the cold spot, usually the necrotic area. This is the image. This is a pre-contrast. This is a pre-contrast, and this is the post-contrast image. In post-contrast image, please see that there is no enhancement in this portion. It is hypointense. That means it's a necrotic zone, and here it is. Some portion is viable, so there is some enhancement of the tissue. So this is it. Now, prognostic indicator actually depends upon 2 points. Is how much portion of the wet bearing surface has been involved in the necrosis process, or what is the size of necrotic area. These two features actually indicate the prognostic indicator. Now there is actually two questions, two data. If the necrotic fragment involves 25% of the diameter of the circle, that means femoral head to be considered as a circle. Just draw a diameter of that head, and if the necrotic portion involve less than 25% of the diameter, then it is a good prognosis. But if it is involved more than 2/3 of the wet bearing surface of the femoral head, then there is a 74% chance of collapse, and that is poor prognosis. This is a I didn't find it actually in the radiology literature. I've taken it from orthopedics literature actually. So this is a carbon necrotic angle. This is given by some carbon necrotic angle measurement, but they are telling that we should measure it in MRI. Firstly, they were telling that we can also measure the angle in X-ray, but it has become now obsolete. In the gold standard become MRI, and I have to measure the angle in MRI. The thing is that we have to take two picture. One is mid coronal section, another is mid sagittal section. Mid coronal, mid sagittal. Now mid coronal section, just think the femoral head as a circle. Just come into the center of that circle and put two lines along the necrotic area. Suppose the necrotic area extends from point A to point B, we have to draw just two lines joining the center here in the mid coronal section, similarly here, and measure the sum of the two angles. If it is X, if it is Y, then the total angle will be X plus Y, and they have given a classification that if it is less than 160 degree, then it is okay, good. Medium is 161 to 190, and if it is greater than 200 degree, definitely it is a poor prognosis. This is actually the measurement. It is given by carbon necrotic angle. Okay, next. Okay, with this we have finished femoral necrosis, avascular necrosis of hip region. So just a quick recapitulation. What I have told, that two imaging feature is there, two imaging modality is mainly there. One is X-ray, another is MRI. The X-ray changes are maybe subtle or maybe not be visualized, may not be visualized sometime. So that's why most sensitive and most specific is MRI. In X-ray, usually crescent sign or subchondral fracture. Crescent sign or subchondral fracture is usually seen, and there is increased zone of sclerosis. Third, which is also called as snow cap sign or head within head appearance, whatever. Next, in MRI, two feature. One is that serpiginous pattern of altered signal intensity in the anterior superior portion of femoral head, and second is the double band sign. Now this, what I have discussed, actually this is actually the basics of imaging of all other necrosis, more or less similar feature. So next come to the lake of Perthes disease. Perthes disease is commonly seen in the young age group. Okay, and if it is seen in female, the prognosis is poor. Okay, it is, and the reason is idiopathic. The reason is idiopathic. Okay, next হচ্ছে avascular leg cup disease, avascular necrosis of epiphysis of the femoral head before the before the growth plate close, and it's seen between the children between the 5 to 7 years of age. This is the X-ray finding. Actually, this is the summary of the X-ray finding. Just see similar thing. I already told the crescent sign, that is the subchondral fracture, increased radio density, also called as snow cap sign or head within head appearance. Another point is there may be increase in I told the joint diffusion, increase in the fluid in the joint cavity, and which displaces the normal fat plane. So the fat plane will be displaced laterally and it will be convex in sepet. Actually, this is known as Waldenstrom sign. Waldenstrom, it is actually a non-specific sign. It can be seen in any cases where there is joint diffusion, and due to that there is displacement of the fat plane. Okay, so first theory I've told is there is soft tissue swelling, there is capsular fat plane will be convex, increased medial joint space with lateral displacement of fever due to joint diffusion. The obturator foramen will be small femoral head. Crescent sign already discussed in previous, in hip case, sclerosis or snow cap sign or head within head appearance, and formation of metaphyseal cyst. Okay, see, this is compared to the right side, the left side of femoral head is small femoral head. The contour is irregular and there is actually sclerosis. May not be evident, the picture quality is not good, but it is a sign of leg cup disease. X-ray. Now it is the MRI. This is an MRI. Please note that the contrast has been put. I have already told that post contrast, the area which is non enhancing is correspond to the necrotic zone, and on scintigraphy this is the cold course, and the joint there is also T2 hyperintense area corresponding to the joint diffusion. This is subchondral sclerosis, non enhancing portion. This is joint diffusion. Okay, this is the progression. The progression has been shown here. Please see that over the time period how the femoral head contour has become changed. And please note in the end stage there is definitely fragmentation, as well as the cystic changes, radiolucency is seen in these cases. Here, after remodeling, there is femoral coxa magna, that is that femoral neck portion femoral neck portion has become short but wide. It has become wide. This is called as known as coxa magna. And coxa plana, that means the femoral head has lost its original contour and it has become more flat in appearance. This is called coxa plana. The femoral neck is get widened. This is called coxa magna, also known as mushroom deformity. What is sagging rope? Sagging rope is that key enlargement of the femoral neck cast a linear shadow has been written in the book. A linear shadow over the metaphyseal region known as sagging rope sign. Okay. Next, same thing. The femoral head has become flattened, along with metaphysis or neck has become broad or in appearance known as mushroom deformity. I've just taken a few more images of avascular necrosis. Already discussed the appearance of the femoral neck known as mushroom deformity, and there is actually necrosis allowing the fragmentation. The prognostic features, this actually put in a MCQ question. Actually, female, if they are present, if a patient is a female, this is a poor prognosis. Another is delayed diagnosis. Delayed diagnosis is a poor prognosis. Earlier the presentation, earlier the recovery. So if a child presented more than 6 years old, this is a poor prognostic indicator. These two questions are asked in exam. Next come to Kienbock disease. Kienbock is lunate osteonecrosis, Kienbock, and it is has a male preponderance. Okay, male preponderance, and the cause, there is no specific cause, but it has been postulated that the manual labor who use their hand frequently, so excessive hand use, or causing repeated microtoma may cause Kienbock disease, and commonly seen in dominant hand obviously, but can be seen in the also non-dominant hand. Okay, next. Yeah, one other thing is the negative ulnar variance. Negative ulnar variance, here you can see that ulna, this is ulna, this is radius, this is scaphoid. Okay, the ulna is short, little bit shorter than the radius. This is the radial styloid process, this is the ulnar styloid process. The ulnar styloid process is shorter than the radial styloid process, and it is called negative ulnar variance. It has been seen that Kienbock disease is frequently associated with negative ulnar variance. Another thing to note here is that lunate, it is absolutely normal in appearance. That is to be said that sometimes we can see that various features of Kienbock disease like sclerosis in lunate, but sometimes the X-ray can be totally normal as seen in these cases. This is a proof case of Kienbock disease. I will show the MRI later. This is actually the, if I zoom it, you can see here, this is the thin radiolucent. Can you see here? This is there. Can you see there is a thin radiolucent area in a crescent sepet known as the crescent sign, representing the subchondral fracture. Okay, this is right. Okay, this is actually the typical finding. This is actually typical finding that increased radio density, and along with that the alteration of the shape or contour of the lunate bone, and this is that crescent sign signifying the subchondral fracture. Okay, similar thing, that is in increased density, subchondral fracture along with the fragmentation. This is the MRI of that patient. This is the MRI patient. Please note here and here there is actually edema in the bone marrow edema present in the this in the lunate, suggestive of a Kienbock disease. X-ray was absolutely normal. X-ray was normal. The first X-ray shown was this patient actually. It is Freiberg disease. It is the avian of second or third metatarsal head. Similar feature, sclerosis of the second. Here, although maybe shuttle compared to this, if you can compare, there is some amount of sclerosis in the metatarsal of second metatarsal head, known as Freiberg disease, avascular necrosis of hip. Similar feature here, we can see that bone marrow edema, and there is a impacted subchondral fracture. Cohelar disease is the avascular necrosis of navicular, commonly seen as boy, and if it is seen in the less age, adolescent age, it is called cohelar. If it is seen in the adult age, it is known as Muller base. Okay, cohelar and Muller. Say this is the normal side, this is the normal side, this is the navicular bone. Compared with the disease side, there is reduction in the volume of the navicular, along with that a thin line of crescentic line or subchondral fracture. You know, already told the sclerosis, volume reduction along with the crescent sign seen in the navicular bone, suggestive of avian of navicular or cohelar disease. This is spontaneous osteonecrosis. This is spontaneous osteonecrosis of knee, or in short, Schonk disease. Commonly seen in women, associated with osteoporosis disease. Some who say that subchondral insufficiency fracture is also associated, and obviously medial femoral condyle is all know that more joint weight bearing portion. It is commonly seen in medial femoral condyle area. So it is called spontaneous osteonecrosis of knee, commonly seen in women. This is the image. Actually. This is the image. Note that the surrounding sclerosis along with a defect in the medial condyle region. In a corresponding MRI, you can see the similar feature, impacted subchondral fracture along with sclerosis and some edematous portion. Has disease. It has disease is most common avascular necrosis of humeral head. Avascular necrosis of humeral head is known as has disease. Please note that most common places of avascular necrosis is hip. Second most common place of avascular necrosis is at shoulder. Shoulder. This is a question actually. Humeral head, avascular necrosis humeral head, most common cause is hip, second is humerus. Okay. Next. Same জিনিস এখানে. This is crescent sign, already subchondral fracture. This is radiolucency, surrounding there is a sclerosis. So irregular articular surface, radiolucency, sclerosis, same thing. This is a progression, so that there is joint space is well maintained. There is crescent sign, it is the initial picture. Over the time period, joint space is decreased, humeral head contour has been lost, along with that fragmentation and collapse. This is the corresponding MRI. We can see that altered area of signal intensity in the serpiginous pattern along with the bone marrow edema. Okay. Dias disease. Dias disease is the avascular necrosis of talus. Usually it is most commonly the post-traumatic causes. Hawkins classification is it's a question actually asked. Hawkins classification used in the fracture of talus classification, and it actually used to for the prognosis of the disease. This is the MRI of that necrosis. This is, please see, that is the avascular necrosis, same picture, that edema along with that altered signal intensity in the geographical pattern. Island disease. Island disease is the apophysitis of the base of fifth metatarsal. Apophysitis, it's a traction apophysitis, usually traction apophysitis of the base of fifth metatarsal. In the tendon, actually in the tendon name is peroneus brevis tendon. Traction apophysitis of the base of the fifth metatarsal, and it is associated with the sports injury. This is an image. This is the image. Here, this is the thing. Enlarged apophysis with distorted ossification and chondro-osseous junction. Actually, there is three things in this here. One is normal apophysis. Another is normal apophysis. Second is that traction apophysitis of the fifth metatarsal, is also known as Island disease. And another is an accessory bone known as os vessalinum. These three things are actually there. Maybe sometimes difficult. So let's see. If we see that accessory bone, accessory bone is oriented along the long axis of the fifth metatarsal, as in this case, then it is not a fracture. It is not a fracture. It is a normal apophysis of a fifth metatarsal. Normal metatarsal. Second, if we see here, this bone is oriented along the long axis of the femoral head. So this is the normal apophysis. Plus piece 3 here, it is perpendicular. This crescentic line. Can you see here? There, this crescentic line is perpendicular. This is the image. This, if it is along the long axis, this is normal apophysis. If the line is perpendicular to the long axis of the metatarsal, as in here, this is actually the fracture. This is actually the fracture of the proximal fifth metatarsal. Okay. And next is, sometimes there is an accessory bone without any. The patient has no symptom. Just come for or it may be an incidental. It is basically incidental finding. Is an accessory bone which is known as os vessalinum. It is the tendon in the peroneus brevis. In the tendon of peroneus brevis. Yeah, I've told here. It is in the peroneus brevis. Okay, next. Camel disease. Camel disease is basically that osteonecrosis of the Vertebral body, usually post-traumatic, commonly seen in the women associated with osteoporosis. Same thing. Treatment is vertebroplasty or kyphoplasty. Collapse of the body of the vertebra. It is common disease known as severe disease. Severe disease is the no. Now there is a controversy. Some say it is a calcaneal. Some say it is calcaneal apophysitis or severe disease. Previously, it was thought to be avascular necrosis of calcaneum, but now in recent literature it is said that it has become a normal calcaneal variant, normal calcaneal apophysis variant. So it's not a disease. Some literature say that, but anyway, it is severe disease. Classical teaching is that. So with this, I have finished almost major portion of the avascular necrosis of major bone area. This is actually some MCQ. From a MCQ point of view, causes of the or risk factor of avascular necrosis is important. Like chronic thalassemia dekha jana, not seen in thalassemia. Other causes are commonly seen: alcoholism, acute pancreatitis, hyperlipidemia, polycythemia rubra vera, Gaucher, Cushing. Already mentioned Cashian disease is seen in definitely scaphoid fracture में देखा जाए humeral neck fracture देखा जाए femoral neck fracture देखा जाए talar fracture देखा जाए not seen in olecranon fracture. Okay, there is this is called transient osteoporosis of hip. Actually it is I have not discussed. Actually this is actually a very rare thing, only mentioned in literature few cases, commonly seen in pregnant women. Pregnant women cases देखा जाए, it is a close differential diagnosis come in the avascular necrosis of hip. Usually the patient is having no risk factor, which I have discussed for avascular necrosis of hip. This is the clue. And pain, actually the key complaint of this patient is they come with the pain in hip region, definitely pain in hip region, but it resolves spontaneously. This is the thing, it resolves spontaneously, not like that avascular necrosis of hip, it resolves spontaneously. And the intertrochanter, it is recurrent, it can be recurred in another joint, these two, and it recovered not 3 to 6 weeks, 6 to 9 months. It takes up to 6 to 9 months, and it can be confused with avascular necrosis. Definitely a differential diagnosis. The main imaging feature actually is written in particular region of the femur. It show high signal MRI in MRI. Okay, this is I have already discussed that staging of Mitchell classification. This they give in MCQ actually. Class A, B, C, D. That first, fat intensity, second is the blood intensity, third is food intensity, and fourth is granulation tissue. And the stage 1 to 3 I have not discussed in detail. That is that pie-cut classification. Pie-cut classification is used for it is an orthopedic classification, definitely based on X-ray MRI. Okay. Next, Kienbock disease. Most common in left hand. No, it is not a left hand because it is most common in dominant hand. But although can be seen in the left hand. Yes, under 75% is no problem. Yes, it is seen in 20 to 40 years. Is managed condition? No, it is not managed condition. Usually the surgery has to be done. Decompressive surgery. Venous condition is a probable cause. Okay, and complication of Kienbock disease. These are the complication actually caused. And another thing is I have not mentioned in that also in MCQ question came a Parthes disease. Parthes disease one classification. You can see that Catterall's classification. Catterall's classification is used in avascular necrosis of idiopathic leg Parthes disease. This is the Catterall classification. This sometimes is an MCQ. So almost we have come to an end. So thank you. Please let me know your feedback for this short presentation so that I can improve myself. Okay, thank you.